So good afternoon. I think we have resolved all of the technical challenges, but we will see during the course of this symposium. So first of all, thank you all for staying around till this symposium where we will be discussing current considerations regarding opioid use disorder. It will be an international perspective, including descriptions of experiences from Iran and from the United States. We are going to start with Dr. Ali Farhoudian and followed by Dr. Ramin Radfar and Dr. Jenna Butner. So without further ado, Dr. Ali.
Thank you very much. Good day, everyone, ladies and gentlemen. And thanks for your attendance. I'm going to talk about a brief story about Iran's situation before Dr. Ramin Radfar exploring the pros and cons of opioid substitution treatment and harm reduction in Iran. Iran is the 70th largest country and the 18th most populated country in the world. Based on the former reports, the prevalence of substance use disorder is about 2.1% in 15 to 64 category of population in Iran, and mostly use opioid and opiates. I would like to introduce the situation and the history of Iran in 6 stages. First, Iran had an Islamic revolution about 15 years old, and before the revolution in 1950, voluntary inpatient and outpatient drug treatment programs were available in Iran. Even in 1917, the opium were legalized, and it was provided for people with severe opioid use disorder and people with specific medical conditions. The important point is that from 1950, methadone was also available as a medication for detoxification in Iran. But after revolution in 1917, Iran granted a zero tolerance to drug use and drug problems. All voluntary treatment programs were closed, and the only available services were mandatory treatment in the camps and mandatory residential camps. Iran started a war. Actually, Iraq started the war against Iran, and the war terminated in 1988. After termination, the war, a shift toward a medicalized approach happened in Iran, and the first outpatient treatment programs provided short-term opioid withdrawal management established in Iran in 1996. They were equipped to non-opioid medications and psychosocial services only. The second shift happened in 2000. In the turn of the century, the incidence of heroin use increased, and HIV epidemics happened mostly in PWID and mostly in prisons. At this time, a lot of scientists persuaded the authorities to establish the maintenance treatment to Iran. Therefore, in 2002, the first opioid maintenance treatment programs started, and Iran was the first country that established and launched methadone maintenance treatment in their prisons, because the problems were in the prisons. The second shift happened, the second improvement happened in 2006. In 2006, buprenorphine treatment programs established, and a rapid increase in the number of outpatient treatment services and clinics happened. At this time, we have over 8,000 outpatient treatment services, all equipped to methadone, buprenorphine, and some of them equipped to tincture of opium in Iran. It was a very good situation for treatment for people with opioid use disorder. In 2007, HIV incidence decreased until 2010. In 1 year, we have 0 incidence HIV in the people with substance use disorder, injecting substance use disorder. And at the 2007, Iran established the clinics, actually equipped clinics to tincture of opium for maintenance treatment and detoxification. In 2005, an increase of methamphetamine use happened in Iran, like the other parts of the world. And this large number of clinics that all were equipped to maintenance treatment without an established and a good, well-structured psychological intervention could not handle the situation. It was the reason that the demand for a stricter policy happened again in Iran after about 20 years, and compulsory treatment returned to the programs. Compulsory treatment is for the patients, for the people who are not on treatment, who are addicted, who use drug but are not in treatment, and for those who make drug-related public nuisance. In 2017, in contrast to the rapid expansion of the compulsory treatment programs, policy toward the criminalization of drug use were paving their own paths. Then we have two separated and opposite policy. A vast numbers of clinics for maintenance, treatment, and a harsh policy for punitive treatment. Iran, for example, decreased the death penalty for drug-related offenses. It was the Iran situation at that time, and it continued so far. It is the Iran situations. A large numbers of clinics, a large number of psychologists who know how to treat, how to therapy people with substance use disorder, and at the other hand, a punitive approach, a criminalizing approach to the people with drug addiction. Let me ask Dr. Ramin Ratfar to explore the pros and cons of opioid substitution treatment and harm reduction in Iran after me. Thank you.
Good afternoon, ladies and gentlemen. I'm very glad to be here. And I will talk about the identification of the socio-cultural barriers of the drug addiction treatment in Iran. As Dr. Ali said, we have a large network of the treatment services, about 8,000 clinics and about 1 million people under methadone maintenance. Agonist maintenance therapies, including methadone, buprenorphine, and also opium tincture. But this is not all the story. There are lots of the problems and there are lots of the barriers. Even now, we have 1 million people under treatment, but we have millions of the people behind the treatment also. They are using methadone, they are taking opium tincture, they are taking buprenorphine from the black markets. Any herbal shop in Iran can actually sells opioid drugs as a black market, and lots of the smugglers also provide at the same time. Heroin, you can buy from them heroin, you can buy methadone, or you can buy them from them methamphetamine, or you can buy all of them. So this is the situation that we have. The results that I want to present is the results of the qualitative study that conducted to detect the barriers. It was 8 people who use drugs has been interviewed, in plus 7 individual families of the family members of the PWUD, 7 service providers, and also 4 policy makers. There are 10 domains identified in this study as the main barriers of the treatment, for the treatment. And one of them was stigma and negative social attitude. Actually, overall, when you study attitude, study on the attitude of the general population toward the opium, not addiction, toward the opium, usually the attitude is not so much negative. The people accept, lots of the people believe that the opium is a good drug for hypertension, good drug for diabetes and for stress, and it is during the COVID, actually it was a very strong beliefs spread around the country, even as a paper. Also, it's a retracted paper, but at least at that one time, it has been published that those who are using opium are immune toward the COVID. So this is the problem, but this is the attitude toward the opium, not toward the addiction. So a stigma toward individuals with substance use disorders is deeply rooted in Iranian societies. You can see many people that are using opium sometimes, times to times. But if a man comes and proposes for his daughter to get married, he will ask that, is he using the drug opium or not? And if he uses, the answer is no. And also the social perception of the addiction as a moral failing rather than the medical condition is very dominant among the people. Many of the people says that, what are you saying that these are patients? They are at the criminal states. And you know that we have also something interesting in our rules, in our law, that based on the law of Iran, substance use is considered as a criminal state. But if substance users try to get treatment, so this is the patient. And we can see that how the ambivalence is toward the systems. Another, the domain was inadequate insurance coverage. Regarding the insurance coverage, I'm a doctor, so I'm under the cover of the insurance. And if I want to buy my diabetic pills, my diabetic medications, it's much easier for me to go to the pharmacy and buy without insurance, because the insurance usually did not cover anything. Maybe some hospital services at the general hospitals, governmental hospitals, has been covered by the insurance, but usually the insurance is not so much active. And what we are talking about, the insurance of the substance use treatment, actually, it's a subsidized. It's not insurance. Nobody's paying insurance monthly and then using his insurance for treatment. This is a services that the Ministry of Health and Ministry of Social Welfare provides some subsidized or some grant for treatment, and it is very low and very ineffective. Another domain is that low quality of addiction treatment centers. The number of the clinics increased rapidly, but the system for training the service providers is very much bad, actually. As a doctor, when you graduate as a doctor from the universities in Iran, you usually takes 1 week or 2 weeks rotation in the addiction as a part of the psychiatric addiction, in not as psychiatry rotations in not all of the universities, in some of the universities. So when you are graduated as a doctor, you don't know anything about the addiction. Then you want to start to work as an addiction therapist. You can go to the same university, register yourself for a 15 days workshop course that it's online. It's no matter that are you behind the computer or not. It should be only online, such as any other online courses. And after 2 weeks, you have certified as an addiction therapist. You can go request for substance use treatment registration, and you can start for visiting patients. This is the same as for the psychologists. So we have thousands, but the level of the education is very low, and maybe this is why that we cannot provide services for methamphetamine users, and this is another problem. Also, there is a shortage of trained professionals who specialize in addiction treatment, as I told you, and also a punitive and security-based approach towards substance users remain dominant in many areas. You can go as a patient to a clinic and take the opium, take the methadone. And you can come from the clinic out and go to the airport and want to have a domestic flight, not international flights. And at the airport, the police will arrest you with the methadone, no matter that you show that I have a certificate that I'm taking the medication from a doctor, from a licensed doctor, from a licensed clinics. It doesn't matter. The police do whatever he wants, and we also do whatever we want, and we are not in parallel with each other. In many of the governmental and even private industries or offices, they do not tolerate employee with methadone use, even the certified methadone use or opium use. This is another problem. The separation between mental health services, primarily in healthcare and addiction treatment facilities, create discontinuation in care. And this system prevents a comprehensive, person-centered approach to address the occurring disorders. Another problem is that lack of the coordination among the institutes. It is good to know that why this separation is that. When we talk about the government of Iran, I'm not talking about the supreme leader that you can see, follow lots of his idea in news. When we talk about the president, we have a president elected by the people. And the president have lots of the ministries, and two of these ministries of Ministry of Health and Ministry of Social Welfare. Ministry of Health has a deputy of treatment, deputy of health. Ministry of Social Welfare has an organization known as state welfare organization. They are in the same level, as you can see. And deputy of treatment certified and opens SUD outpatient and hospitals. Deputy of Health at the Ministry of Health provides DIC, outreach, VCT, female sex worker services, clinics, even for the gay and lesbian services. They are all run by Deputy of Health, and also a state welfare organization opens support outpatient clinics and residential settings as well as TCs, DICs, and FSW services and outreach. Two completely different ministries do the same thing at the community level. And they are usually, they believe that the other organization is not working good, and this creates a problem. Another interesting thing that you can see a question mark, and this is that neither of these two ministries can can offer, but they cannot confirm a protocol for treatment of substance use without approval of the drug control headquarters. And drug control headquarters that has money and that supports the money of for drop-in centers, for harm reduction services, especially for the harm reduction services, usually are run by retired colonel and generals from the Ministry of Interior or disciplinary or police and disciplinary force, and there is no need to say that how is their attitude toward the harm reduction. They say that we are, as Dr. Farhodian told, that we have some residential campus known as Article 16, and they take the homeless substance users to this campus in a very bad situation. And this is the experience that they are very similar to narcotic farms that we had seen in 1940s in the United States. And they say that this is the budget, this is the harm reduction, but the harm here is not substance user. The harm here is the robbery. When we take the homeless users, homeless substance users to this campus, the small robberies decreased, and this is a type of the harm reduction. So the budget for the harm reduction shifted to this residential campus. And drop-in centers, ordinary harm reduction services now are suffering from the lack of budget. Also, sorry. The other domain is that medication-assisted treatment is available, but psychological and counseling services remain expensive and inaccessible for many people. If you want to actually get the services, you can go in the clinics has to have they must have psychologists with themselves, but these are very untrained, unprofessional people, usually just by the 10 days workshop, something like that. And they are usually, their task is completing the forms for the file of the patient, that if somebody wants to check and supervise the clinic, says that, okay, there is the psychologist exists in the clinic, that's it, no matter what is the services. The other part is the cultural norm and family dynamic can also hinder treatment. Some families may deny the existence of addiction due to shame or fear of public health. There are studies that shows that the average time that the families will accept and understand that the member of the family is a substance user, it's after 5 years. The people are using this substance for 5 years, and after that, the family accept, okay, no, there is a problem, and it seems that there is a problem. We may have to do some things. The others may resist treatment option and involve medication or inpatient care. You have lots of the patients that the patient is using. This is the experience that everybody usually has. When I'm in my office, I can see many patients that are using heroin for 20 years, are using methamphetamine for 7 years, 10 years, something like that, and many other drugs. And when I want to start the medication for them, when I want to start the methadone, when I want to start the naltrexone for them, the main question of the family is that, doctor, are you okay that there is no side effect for these drugs? And my answer is that compared to the side effect of these drugs, the other side is not yoga, the other side is not exercises, the other side is using the heroin. So when I want to compare the side effects, so this is not a real comparison. But many of the people says, no, we think that the residential campus are much better. There are mid-term private campuses, and they take the patients for 28 days without any medication and just keep the patient at this campus. And the family says, you know that the methadone is an addictive, so we want to put our son from the opium to the methadone. At least the opium is natural, but the methadone is synthetic drugs, and there are lots of the much side effects for it, and this is the negative attitude toward the system. Failure to inclusive policy making that incorporate the views of service users, families, and clinicians and other stakeholders. This is another problem. Policies created without input from the directly affected substance users. When we talk about the participatory method, anybody around the world knows that in participatory continuum, you has to have the ideas and opinion of the main stakeholders, and this is not completely acceptable in Iran. So these are the actually the barriers, the main barriers that has been identified. I hope that someday we can resolve this. Thank you for your attention.
So thank you. Why don't we take a few questions now for the first set of talks from Iran, and then we'll move to our next presentation. Are there any questions?
Thank you very much. That was impressive, brilliant presentation. And what I see, my name is Dr. Kancho from Sofia, Bulgaria. I'm president of the Bulgarian Methadone Treatment Association. So what I saw today is very, very dear and close to what we have been going through for many years. And I suppose this is very nicely presented summary of the problems, barriers that we have in Europe, Iran, many other parts of the world, I believe in every country. So the question mark stays. We've done a lot, and what we've done is the result of the effort of a small number of missionaries, of pioneers. I believe it's all over the same. But going to the question mark, what to do? What is moving forward to our goals? What you find effective in your efforts to influence drug policy and government decisions and decision making would be very precious to hear.
Thank you very much for your question. Actually, you know, there are two types of the governments and governing, actually. One of them is that by the system, and another one is that by the persons, usually known as the dictatorships. In dictatorships, you have to pray that somebody be a good dictator. So when you find a good dictator, it would be by chance, actually. Dr. Farhoudian presented, and in the sixth phase that he presented about the changing the attitude of the government toward these are very parallel to the changing of the presidents. Sometimes we had a president such as President Khatami that wanted, that established the civil dialogue theory for talking with the civilization with each other. At another time, we had some president that wanted to vanish around all of the countries around the world and are fighting against all of the wars. So one system is the praying, actually very hard. Actually, it would be good if we can have good dictatorship. Another one is that I believe that finally we have to show that the evidence are much better than, this is a very, very, very hard process to persuade the policymakers about that this is not what you think. But finally, we can say that, fortunately, by the scaling up the networking of the peoples and social media and many other instruments that we have, now we can share the results with the general population. And finally, when the general population accept that the treatment is working and treatment is not only stopping using drugs, finally they can ask the policymakers to do more evidence-based actions. I believe that maybe this is the way. But in Bulgaria, in Eastern Europe, I know that we are very similar to each other. We have very similar situation and problems similar to each other. Dr. Farin, do you want to add something? Yes.
Sit there.
Pardon?
Thank you so much for your very, very interesting presentation. One thing that stood out to me is that you mentioned during COVID, those who used opium were seen as you said, like immune. So I was really hoping you could comment on that. I have some of my own ideas, but I would love to hear more about that.
Thank you very much. Actually, the story started from just one person who were talking in Instagram that the opium users are not taking COVID-19. This was only a substance user was telling, and this is going to be viral. After that, you know that the prevalence, actually the incidence of the COVID among the different provinces were not similar to each other. And we have one provinces that is a very, 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 very large provinces with low density of the people. And they are using opium as a very traditional in any party. The opium serves as a tea, as a coffee or something like that. And because of the provinces has a very low density of the population, the incidence of the COVID at that time was low. And somebody thought that, oh my, this is, you know that there are provinces with lower using of opium that they had higher rate of the incidence of the COVID. So this is why, and unfortunately, the paper has been published in just predatory journals. But you know that when you, in non-English countries, when you publish something as in English, for many people it seems that, oh, this is like such as Quran, and so everybody has to accept at that, and that it was really was a problem. Still now, even now, after years, we can see the patients that says that we started the opium during the COVID and for stopping. And you know that it was also effective on their cough, so their cough was also lowering, their pain actually, and many other people. So this was actually what happened.
Thank you for your question. In the first month,
yeah. Thank you for presentations. I am addicted doctors. I treat people from opium addictions and heroin. I have all times feelings, heroin addictions, that's easy to me. And when I treat people with opiums, that's a big challenge. I don't understand that's dependent on the drugs or on cultures. My question is, if you have in Iran only heroin addictions, no opiums, and you think that will be easy to treatment for people and will be, yeah, if that's only heroin, no opium.
No, actually, no. Actually, the main opium users, opioid users in Iran are opium users and not heroin users. About 75% of all of the opioid users in Iran are using opium rather than the heroin. But those who are in the end of the continuum of the addiction mainly use heroin, actually. And this is...
We recognize these cultures also in Western, that people will come here, they go to gatherings and they were smoking opiums. I think maybe for these reasons why people like all times to use it, such as communications, such as Yeah, they have together actions. Are you agree about that, or
Sorry, I didn't
people together?
the point. Did you get the point?
No,
Actually,
interactions, cultures,
can you speak?
Could you repeat the question, please?
participations. Yeah, together.
Could you repeat it? Ask it again.
Please repeat your question. Actually,
Yeah.
We couldn't hear the question.
Yeah. In Holland, I see people coming together. And
sorry, when you talking and taking your mic,
Yeah.
I don't.
And they're smoking opiums together, peoples, yeah, many peoples, yeah, and I think that will be perceptions or interactions, cultures together with opiums, yeah, and I think that heroin that's another's using, yeah, that's maybe individual, but opiums the people together, cheerings, drugs. And maybe that's the big challenges to treatment. I think so. I don't know what you think about that.
I'm not sure that I understand your question or not, but regarding the cultural using of the opium, actually, if this is this your question?
Yeah.
So, did you get the question?
If I understood, you're asking that in Iran, opium tincture is provided to people, and they may use in a gathering and spread the use, yeah, spread the consumption.
Yeah.
Is okay? Yeah. Thank you. To my knowledge and opinion, it always can happen as a diversion. Diversion is not just selling your drug. Diversion is giving your drug to another person that doesn't need or did not receive it from a clinic. It can happen even for methadone, buprenorphine, and also as well opium tincture. But the opium tincture that provided in Iran is not raw opium. It's a tincture, 1% opium, and the others are a solution that is given to the patients and is under observation, under supervision, with a limited take-home, like methadone, like buprenorphine. But yes, your concern is correct. Some of people may use it with the other people, like methadone, and some may use it and raw it, drive it to exact opium and use with the other friends. It's happened.
Yeah, understand. Thank you. Yeah.
Let me add something to what Dr. Rothfast said about the last question, opium use in COVID time. You know, ISAM conducted a survey in the first months after pandemic announcement. And we received, at that time I was managing the data, and at that time we received data and information from 77 countries in the world. And one of the main questions was about the prevalence and incidence of drug use after COVID in comparison to the previous. And we realized that in a lot of the majority of countries, the incidence of opioid use, amphetamine use, and other illicit drugs increased. But the incidence of, for example, prescribing drugs decreased after COVID happened. Maybe, I don't know. This also happened in Iran. And it's not only for the rumor that opioid is good, but also because of the lockdown or other social situation and risk factor. Maybe, I don't know. We never studied that.
Well, thank you for this discussion. Maybe we'll move forward to the next presentation, which is from Dr. Jenna Butner from Yale University in the United States, who will be presenting next.
Is this one right?
All Great. Good afternoon, and thank you for having me speak today. Thank you for that really fascinating presentation on Iran. I'm going to be coming from it at a different angle and just giving the U.S. perspective. So thank you for having me. And I have no disclosures. So the objectives of the talk today are to discuss the epidemiological shift of OUD prevalence and just patterns in the US over the last decade or so. I will touch on some legal and political barriers to OUD treatment and not go into them too much, but we'll discuss. I'll provide some state-specific examples of harm reduction efforts that are currently underway. And I will discuss current and future treatment methodologies of OUD. So before we start, let's just take a quick look at the vital statistics. These are from the Centers for Disease Control. And you could see here, so this is the change in drug overdose deaths. And you could see that in around August of 2023 was the peak of overdose deaths. I believe it reached around 112,000. Oops. So now you can see that for the first time in US history, we are finally on a decline of overdose deaths. So I think that this depiction is very telling. And I'm not going to go into, well, actually in the next slide here, so we see a breakdown of overdose deaths by drug class, which is not to say that, drug overdose occurs with just one substance. In most cases, it's multiple different substances. But the main distinction here is that you could see this on this black line on the top. This is referring to, the black line and the light brown is essentially referring to highly potent synthetic opioids. So the US over the last under 10 years or so has seen a dramatic influx of fentanyl and other now even newer, we see nitazines and xylazine, which I'll talk about in just a moment. But really here the point of this is to see the distinction between the overdose deaths caused by these highly potent synthetic opioids versus down here, hopefully you can, oh, sorry, you can't see my mouse, down below on the green and light blue lines are essentially morphine and heroin. So we're seeing a lot less overdose deaths due to that. And in addition, we see here as well, overdose due to prescription opioids has gone down dramatically as well. I do want to point out on this pink line, this is overdose involved cases with cocaine, with stimulants, as well as with the light gray line is for psychostimulants. And as well, just keeping in mind, I mean, it's very uncommon to just see one overdose death due to just one substance. So just keeping in mind that this can certainly, it's not as clear as it might look. So further looking at opioid-related and other drug poisoning deaths per 100,000 people. So this is a pictorial of the US from 2021 to 2023. And you could see the prevalence has not changed much. We were mostly seeing in the Northeast, so New York, Connecticut, where I'm from, Vermont, Maine, kind of that Northeast tip of the country, was seeing incredibly high rates of overdose. Also to draw your attention to the Appalachia area, which is the kind of darkest point here. It's where there's Kentucky and West Virginia, which is seeing a dramatic, is still presently seeing a lot of overdose deaths, but also due to co-occurring amphetamine use as well. And then as well, in the south, so you could see here in the southwest, we have Arizona, Nevada, Louisiana. So we're seeing a lot more overdose kind of coming down a little bit southwardly. What stood out to me on this is that the overdose deaths increased dramatically. This is Alaska on the bottom left, and the increase in prevalence of overdose in Alaska specifically, because we're seeing highest rates of overdose in many indigenous populations. So I think that this is, and the Indian Health Service Administration. So I think this is important to still, to include Alaska, also Puerto Rico, which still continues to face incredibly high rates of overdose. But as you could see, the shift is there, but it's still quite common throughout in rural, urban settings, et cetera. So I figured before we talk about, or after we talk about overdose, what substances are we seeing in the US? So this is a pictorial from a program actually in New Haven, Connecticut. It's run by Stash ID and Liberation Programs. So it's a community drug checking program where people can bring their samples and they're analyzed under this FTIR spectroscopy. Thank you. Thank you. All right, so we also are using test strips, so mostly fentanyl and xylazine test strips. So you can see in the top left, just to go through a few examples, this is a sample that was bought in New Haven. It was bought as fentanyl. The test strip was positive for fentanyl and xylazine, negative for benzodiazepine, but the FTIR result of the substance was caffeine and mannitol, so basically a cup of coffee, caffeine and sugar, and then minor trace of fentanyl and unknown amount of xylazine. Let's take a look at another one. The bottom left, so we see here was bought as fentanyl, and the test strip result was positive for fentanyl and negative for xylazine and benzos, and the results showed that, again, major component of sugar, fentanyl major, procaine major, and we're seeing more actually dexmedetomidine, which is a CNS depressant. I'd be curious to know if other countries are seeing this in their drug supply. And let's see, we'll choose one other one that's interesting. The middle bottom. So this sample was purchased as fentanyl, and this is all in New Haven, actually where the Yale campus is. So this was bought as fentanyl, and the test strip was positive for fentanyl, negative for the others. And it was a major component of sugar, once again, and we're seeing this BTMPS, which is an industrial chemical that can cause cough, blurred vision, nausea, vomiting. So we're seeing this in the supply. Inositol, another sugar, and then just minor amount of fentanyl, and then trace amount of, again, dexmedetomidine. So all of this to say is that we really need to empower patients who are actively using to engage in this community drug checking, and it's also completely, at least this program, completely anonymous and safe, and no questions answered. People can just bring their little baggies to them. So I just wanted to talk a little bit about xylazine. And before I turn the page, just warning, there is a graphic image. So we're seeing a lot of xylazine in the drug supply. This is actually an article I wrote, I do some work in the hospital. And we're seeing patients are coming in, they're Very, very few are actually using xylazine deliberately. Again, as you saw previous, it's more of a contaminant in a lot of the drugs. And just to review, xylazine is an alpha-2 agonist. It's a veterinary sedative, an essential nervous system depressant. And it's been incorporated in the US drug supply since the early 2000s, and it was initially seen mostly in Puerto Rico, and then it was on the scene in Philadelphia, which is also unfortunately home to a very bad situation with substance use there. And then in April of 2023, the White House put out a statement. The Office of National Drug Control Policy, they officially designated fentanyl adulterated or associated with xylazine as an emerging public health threat. So I definitely commend the ONDCP, not UNODC, for coming out and kind of tackling this head on. And since then, they've come out with a plan of how to approach this. And then just from a clinical perspective, where the patients that I was seeing in the hospital were coming in with these really awful skin wounds and skin necrosis that could be years. There's no treatment for the skin wounds except for wound care. And as far as xylazine itself, when it's involved in overdose death, there's no reversal agent for it. So the recommendation is to, never use alone, and to have Narcan on hand. We know that it won't affect the xylazine, but that is the recommendation. So this is all just a little snapshot of the actual drug supply of what we're actually seeing. And not to get too much on the more political side of things, but the influx of fentanyl and xylazine, the majority is coming through Mexico, as well as through China. Those are the two countries where we're seeing the most export or import of. So let's jump into some state-specific examples of harm reduction interventions. So first I want to start off with talking about Oregon, which is top northwest of the country. So they were the first state to actually decriminalize small amounts of unregulated substances. So in 2020, ballot measure 110, as I said, decriminalized possession of small amounts of all drugs, whilst greatly expanding addiction treatment and social support. And this provided over $300 million for addiction services, also including programs where law enforcement and police were able to care for people without that punitive criminalizing aspect. So it was the first of its kind in the nation. Unfortunately, in September 1st, 2024, state leaders, quote, recriminalized drug possession. There was a lot of backlash from communities, and there were many disinformation campaigns, and the statewide criminal penalties unfortunately returned. I did come across this article that I believe is not out just yet, and it's from the International Journal of Drug Policy, titled Public Calls for Service to the Police. So they looked at trends before and during possession decriminalization in Oregon. And what they found was actually that the ballot measure M110 had no significant or sustained impact on 911 first responder call volume for crime or disorder from 2018 to 2023. And the trends in police service calls remained consistent with those in similar cities without decriminalization, suggesting that M110 did not alter public demand for police. So very important to have these publications that kind of tackling that disinformation campaign. Moving on to New York. So New York City, where I'm from, On Point, New York City was founded in 2021, and it was serving mostly, if you're familiar with Manhattan, Washington Heights and East Harlem, where there's a large population of black and brown individuals who, this was the first organization to launch 2 overdose prevention centers. However, I will note they were not state sanctioned, so that is the difference between that and then the next one we'll talk about. And as you know, at safe consumption sites, they offer safe use supplies and then connectivity services to mental health and just basic healthcare, peer support, and mental health. So in January 2025 of this year, so Rhode Island was actually the first state-sanctioned overdose prevention center in the nation. So very exciting. This was in Providence, which I believe is the capital, hopefully. And this place, it's a nonprofit funded. It's called Project Weber and Renew. And again, it provides a safe place for people to use drugs under medical supervision. And it's really served as a model for other states. There have been other states like Pennsylvania that have tried to pass these through their governments, but unfortunately have been knocked down many times. But hopefully this will start the trend in creating these. So where I practice and where I'm from, Connecticut, so there is currently a bill in the Senate and the House. So it was initially called SB 1285, an act establishing an overdose prevention center pilot program. However, that was just recently in the last week merged with a different Senate bill, an act concerning protections for access to health care and the equitable delivery of healthcare services in the state. So this was actually, just received this information, it was passed in the Senate on May 22nd, and it was sent to the House and is pending approval. And this would be the first of its kind actually in Connecticut. And just from a public health practitioner perspective, we can learn and have innovation in treatment and what have you, but it's really important that people get on board with advocacy for bills such as this. I do have a colleague and friend of mine her name is Dita Bargava, and she is a parent advocate. Her son Alec died of an overdose in 2018, and she's really spearheaded this campaign within Congress in Connecticut to have this bill passed. Just a quote from one of her articles: "The biggest problem we have right now that we can't keep people alive long enough to be able to put them on a permanent path to recovery. With fentanyl, you're racing against time." So I think it's really important that, again, innovation, treatment, all this, but hearing from people with lived experience or parents or families, this kind of narrative medicine type approach is something that has gained a lot of traction in the US and hopefully in other countries, but I think it's important to hear the voices. I do have a small clip from Instagram. I have no clue if it'll run, but it's just a very quick interview of her, so I'm gonna try. Let's see here. Okay, that's not working. All right, maybe we can get it after when I'm done. So anyways, so just advocacy, Dita specifically was working with our presidential nominee, Kamala Harris, to pass a lot of these bills, but unfortunately, that went a different way. So, and now I just wanted to talk a little bit about the treatment that we have now available. So current and future treatments for OUD. So I wanted to put this slide actually at the beginning. This is basically the pharmacological, quote, innovation that we've had for opioid use disorder. So in 1972, we had approval of methadone oral liquid, It was highly regulated under 42 CFR Part 8, and it had to and continues to still be dispensed through certified opioid treatment programs for opioid use disorder. It cannot be prescribed still to this day in a primary care type setting. In 2002, we had the approval of buprenorphine sublingual, and this was under the DATA 2000 X waiver legislation, and what this meant was that providers could start prescribing buprenorphine. However, we were limited, I know when I got my X waiver in the first year, limited to 30 patients, and then the next year you were able to treat 100, and then around 2016 or 17, they increased that number to 250. But I don't know any other medication where I'm limited in the amount of patients I can prescribe medication. Just jumping ahead a little bit, after COVID, so in January 2023, the DEA actually removed this this X waiver rather, and anybody with a Drug Enforcement Administration license can prescribe buprenorphine and any controlled substance in the country now. So that was one positive thing that came out of COVID. In 2010, we had approval of naltrexone extended release injectable. It was prior use for alcohol use disorder, as you know, but just 2010, a decade and a half ago, not too long ago, was approved. And then lastly, in 2017, we have the advent of these long-acting injectable buprenorphine depot injections, extended release, which have come out in a variety of different formulations. However, just thinking about it, with diabetes I just looked this up, there's around 60 different unique anti-hyperglycemic drugs. For hypertension, there's about 130. For HIV, there's about 30 antiretrovirals. And for OUD, we have 3. So just giving that framework of, the work that certainly needs to be done. So hopefully this stands out for you. Of course, we have non-pharmacological OUD treatment modalities, none of which are FDA approved, with the exception of one which I'll talk about. But as with all treatment, behavioral treatment, some of the evidence-based treatment with cognitive behavioral therapy, motivational interviewing, 12-step facilitation, so this peer support model, Narcotics Anonymous is still very active in the US, along with Alcoholics Anonymous, some other modalities, mindfulness-based relapse prevention, and then therapeutic communities, long-term residential, so we call sober living. And then in terms of the digital therapeutics, there are several for just substance use disorder in general. However, just to bring your attention to 3, we have use of CBT for CBT, which is an online-based CBT program for, not specifically for OUD, but just for substance use disorders in general. There was Reset-O, which was one of the first FDA-approved adjunctive treatments for OUD. It has since been removed from the market, if I'm not mistaken. However, it is notable that this was one of the first approved, and then others like the HS, et cetera. But I found this article that was published within the last year in Nature Medicine. So it looked at the advancements in AI, in artificial intelligence, and it showed that they offer scalable approaches to kind of systematically identifying at-risk people. So what this study did is that it utilized this, quote, convolutional neural network to analyze EHR, so electronic health records, notes in real time, identifying patients at risk. It wasn't superior to other traditional means, but at least it's a novel approach to trying to identify those who are at risk. So just some key takeaways. We really need to consider, especially now, the kind of social, cultural, political, economic aspects, a lot of the treatment and innovation is, of course, driven by pharma and what have you. The innovation in both behavioral and pharmacologicals is really crucial. And then lastly, the inclusion of people with lived experiences, just hearing their voices via narrative medicine is truly an effective way for advocacy, innovation, and change. So that is my presentation. I just want to acknowledge Dr. Patenda, Dr. Baldacchino, Dr. Kaveh Khoshnood, and Jeanette Tetro, and then Dita Bargava, who was so gracious to allow me to share her story. Thank you.
So thank you. We can take some questions.
Thank you for a great presentation. On the early slides where you reviewed the opioid overdose mortality statistics, I'm just wondering if you could maybe comment on if there were any changes in naloxone availability or utilization, and if there was any statewide variability that might contribute to understanding those changes. I'm not familiar with it in the US in terms of that particularly.
Yeah, the question was the relation between the overdose death over time and the availability of naloxone. The availability of naloxone, it's, still to this day, so there's many programs where it's just this blanket open prescription, and anybody can go up to any pharmacy and request naloxone. However, it's very often run through insurance, so it's not free per se. I know I've gone to pharmacies and just out of my own curiosity, and I think my copay was $70 for one small box. So yes, it has become a lot more available. There are, of course, mobile vans and community outreach where they give it out. But I do think there is a long ways to go in the mass distribution of naloxone in general. So thank you for bringing that point up. It's very important.
Hello, my name's Melanie McLennan, and I'm from New York as well, and I wonder what you think about GLP-1 and addiction in general.
Yeah, great question. So what do I think of GLP-1s on addiction treatment? I think certainly for alcohol use disorder, I think everybody, with alcohol use, not everybody, but many people would benefit from it. The problem that I face, and I'm certainly you can attest to, is getting insurance approval for these medications. Unfortunately, I would use it a lot more if I could. But I would say specifically, not for OUD, but specifically for an alcohol use disorder is one that I would go for. But I'm very unsuccessful in getting it approved, and in the US it's very expensive.
Other questions? If not, I'd like to thank our presenters and thank the audience.
Thank you.